Okay, so let's talk about some of the specifics for doing a well child visit for the 2-month-old and the 4-month-old. So you're going to start the 2-month evaluation interim history by asking the parents if they have any concerns or anything they're worried about with the baby. And then you're going to ask about the nutrition. You're going to ask if the baby's formula or breastfed and what the schedule is like, and if it feels like the baby's nursing and latching on and emptying a breast, and evaluate a feeding session if you haven't done so in a previous visit, although it's probably more helpful to do on a previous visit. You're also going to evaluate the elimination, and you want to know the number of wet diapers and the number of stools and what the stools look like. And they should be sort of sticky yellow mustard if the child is breastfed, and more seedy yellow if the child is bottle fed. And there should be no history of difficulty passing stools. You also want to ask about sleep. And we know mother needs at least 1 hour, 1 6-hour stretch of sleep to get sufficient deep sleep to be rested, and that the baby now has one period during 24 hours where they should actually sleep to 6 to 7 hours so the mom can get a little more sleep. The baby is sleeping a total of 14 to 16 hours per day and is able to filter out the household noises and really sleep well. We also expect by 2 months that the child will have some periods of alertness, usually around feeding times, and it's fun for the parents to have some time to interact with the baby during those periods. We also want to ask about any illnesses, and it's important to educate families that feeding intolerance can be a sign of an illness in a child this age, both vomiting and diarrhea or just not eating well. And any fever of 100 or greater, we really want them to call the office, and the children usually need to come in and be evaluated. Or if the child is lethargic or fussy, those are signs that we need to see them. We also want to know about the immunizations, and we know that the current recommendations for the 2-month-old child are changing annually. The ACIP puts together current recommendations, and these could change annually, but you want to give the IM injections in that upper third of the lateral, the vastus lateralis, and this slide depicts nicely where that muscle is, and so that you will avoid any blood vessels or nerves and give those immunizations correctly. The 2-month evaluation for immunizations, you want to always refer to the current CDC immunization recommendations, and I've listed for you what's current as of today, but even by the end of this course this could change. So currently, as of today, hepatitis B, rotavirus, the DTaP, and that's the acellular pertussis, the Hib, the PCV, and the IPV are current recommendations. We also want to conduct a thorough physical examination on the 2-month-old, and that includes the length, weight, and head circumference plotted on the growth charts with the percentiles, as well as the vital signs with temperature, heart rate, and respiratory rate. And make sure you know what the norms are for that age child, because it changes very quickly in this first year of life. We also want to look at the head for any plagiocephaly, any seborrhea, and document the size of the anterior and posterior fontanelle. We want to look at the eyes for how well the child is tracking. There should be no nystagmus by 2 months. Look for tearing. The tears begin to be present at 2 to 3 months, and excessive tearing is a sign of dacrostenosis or a plugged tear duct, so that needs to be evaluated as well. We also want to pay attention to their little mouths. Thrush is pretty common in this age group, and you want to look for shortened frenulum, if the tongue doesn't protrude to the lips, it can affect the child's ability to suckle well, and nurse or bottle feed can be difficult, so you want to evaluate that and look for any clefts, both palate and of course lips as well, and then any natal teeth. And we want to evaluate for any heart murmur and also the femoral pulses. We expect at this age for both the upper and lower pulses, brachial and femoral pulses, to be equal in children at 2 months. And we want to evaluate the abdomen and genitalia. The cord should be off, and you want to look for both umbilical and inguinal hernias, presence of any hydrocele or any labial adhesions. We also want to pay attention to the extremities. Can you abduct and adduct those little hips? Then there should be no click. Look for any tibial torsion or metatarsus adductus. There shouldn't be a real curve to the lower leg, and we shouldn't have club feet present at this age. Evaluate all skin rashes and birthmarks, hemangiomas or bruises, Mongolian spots. Make sure you document all that. And we also want to document and evaluate the growth. At this age, we really expect the child to grow about an ounce a day, and for the height to increase about 1 inch a month. And as you get the head circumference, you want to get the occipital frontal circumference, and all of those things, as I said, should be documented on the growth chart and in the chart with percentiles. We expect that occipital frontal circumference to increase about a centimeter per month once the child reaches 3 to 6 months. Next, we're going to assess for the developmental milestones. And when you hold the child in ventral suspension, as the graphic depicts, the child should maintain their head in the same plane as the rest of the body. So the head should not droop down. The child should be able to hold it up at least on the same plane as the trunk. The hands should be largely open at this point, and when prone, the chin should be off the couch. So as you can see with this little baby's photo in the lower right hand corner, that child has their chin way up and the head way up, but should be at least off the couch at this age. And should have their face at least a 45-degree angle. And as you can see, this child is almost at 90. And then they should smile and vocalize when talked to, and eyes should follow a moving person. The developmental red flags at 2 months. We really want to pay attention for feeding skills and fine motor skills. So feeding that takes over 40 minutes, that's a red flag, and those children should be referred. And many times, as I mentioned, the issue is a cardiac issue or a respiratory issue, and the rest of your physical exam will indicate where you're going to refer. But if it's taking more than 40 minutes for this child to eat, something's wrong. Food refusal or resistance is a problem, problems with choking or gagging, and then hands fisted that do not open and close can be a problem. Any child having trouble with sleep-wake cycles and behavioral problems should be referred. So continued difficulty if a child has to be awoken to feed, that's not normal at 2 months. Or children who are irritable and cannot sleep. Other developmental red flags: reflexes and gross motor, scissoring or stiffness, increased muscle tone, that's an abnormal sign, can go along with cerebral palsy or CP, back arching, lack of reflexes, the startle reflex or excessive clonus, those are abnormal in the 2-month-old. Unable to lift their head off the mattress or turn side to side when prone, is any minimal or asymmetric arm and leg movements at 2 months, those can be red flags. Any social interaction and language red flags that we would refer for are the inability to hold alert state and look at the parent's face or an object, and any problems with interaction clues or hunger cues. So we're going to refer if there's no response to pleasing sounds when alert, any signs of neonatal sepsis, meningitis, or asphyxia, any familial deafness needs to be evaluated, any renal abnormality need to be evaluated, and then the anticipatory guidance. Let the parents know that crying behaviors is at its peak, and evaluate how the parents are coping and what strategies they're using to calm the colicky child, and then also evaluate for social smiling and let the parents know that the child should respond with a smile during periods of alertness, and that they need to read the baby's cues, talk to the baby, smile back at the baby, interact with the baby. Talk to the infant. That increases the child's verbal and cognitive development. And reading to the baby, as we mentioned before. Emphasize safety, that even though it's not common for the 2-month-old to be rolling, they should be rolling by 4 months, and that when they're crying and kicking, rolling over and toppling onto the floor can happen at any age, really. So if they need to leave the child alone, put them on the floor, not to ever leave the child alone in water, and then watch for any behaviors that are self-consoling. So putting the child's fists to the mouth or fingers to the mouth, or any type of other infant consolation, self-consolation, bring that to the parent's attention. They reinforce that you should delay the introduction of solids until 4 to 6 months, and reinforce the child care issues. A safe place, usually with a minimal number of other children in the home, is best, and what immunizations should be given and why. So when we talk about the anticipatory guidance around safety, we want to make sure that the child's in a rear-facing car seat, that the parents know they should be supine on a firm surface. Room sharing is great so that the parents don't have to go to another room to pick the child up, but bed sharing, there's controversy about, and we'll talk about that. Breastfeeding, pacifier use, no secondhand smoke, avoiding drug and alcohol use and overheating, smoke alarms in the home. Rolling is possible, as I mentioned before, so placing the child down so they can't fall, and safe play areas, and then discouraging any secondhand smoke exposure, and if the parents smoke, that they don't smoke around the infant, that they smoke outside, and they have a smoking jacket. They take that jacket off when they come in, because those smoking byproducts can be on the clothing, and the baby can inhale them from being exposed to the clothing. Toys for a 2-month-old remind the parents that the child learns through tactile, auditory, and visual stimulation. So music boxes can be soothing and stimulating. Mobiles or crib gyms can be really stimulating for the child. Soft, cuddly toys for the tactile stimulation. Rattles for both the auditory and the tactile stimulation. So those are all good suggestions. The co-sleeping controversy has been raised, and there's a variety of different things that you can read. The whys are for physical and emotional closeness, ease of breastfeeding, alleviation of nighttime problems and children's fears. If they're in a home with only one bedroom, there might not be any other options, and families frequently tell us it just happened. The why not? It disturbs parents' sleep, it interferes with parents' intimacy, it can result in suffocation and leads to disapproval by um, so what we say is that the controversy continues. If they're going to sleep with the family, make sure that it's safe and there's no pillows or blankets that the child can suffocate. And frequently this is a topic that students will do their anticipatory guidance paper on. So let's talk about a frequently seen problem that occurs in this 2-month visit, and that's labial adhesions. It's fusion of the tissue between the labia, sometimes also referred to as labial agglutination, labial fusion, or synechia vulvi or vulvar adhesion. The cause is hypoestrogenation of the vaginal tissue, or if this area becomes irritated because of trauma or poor cleaning is a common cause. And this graphic depicts exactly what the problem is, and many times it happens in the posterior and can go all the way up. So for labial adhesions, the incidence it most frequently occurs in the 2 to 3 month old, and again in the 6 to 7-year-old, more at that age because of mechanical manipulation or masturbation. It can persist into puberty. The incidence is 1 to 3%, slightly incidence incidence in children who've been sexually abused, but again occurs pretty frequently in children who have not. This is a good photograph of labial adhesions that can occur with varying degrees of severity, and your objective data that you will see is usually a thin, flat, pale membrane that can occur at varying lengths between the labia. It usually originates at the posterior fourchette, as I mentioned before, and progresses anteriorly. The management of the labial adhesions varies depending on the severity. And if there's no UTI involved, no obstruction or parental concern, you can reassure the parents, give them good observation and education around just careful cleaning. If it's complete like this photo indicates, you're going to give a trial of A&D every night at bedtime for the thin adhesions, and apply with a Q-tip and some gentle pressure. And you're going to actually retract or give gentle pressure to open, apply a little tension to those labia to try to clean real well, and then apply some gentle pressure and the A&D. If it's severe, like this is complete, this photograph is complete, you may want to move to Premarin vaginal cream, 0.1% BID for 2 to 4 weeks, and then follow with once a night at bedtime for 2 more weeks to produce separation. And that works in 90% of the kids within 8 weeks. After separation, good hygiene and continuing the A&D for 6 to 12 months is suggested, just because once these adhesions occur, they're likely to reoccur. So let's consider a case study for a 2-month-old. Jordan is a 2-month-old term baby. There was a normal pregnancy and delivery and normal growth parameters. Mom is concerned because Jordan is not rolling over yet, and she's wondering if he has some kind of developmental delay. What other questions would you need to ask mom, and how would you advise her? Take a few minutes and then we'll discuss more about Jordan. Some additional questions that I would ask this mother: are there any other concerns around the child's particularly gross motor development, because those are the concerns she's raising today. So how is the muscle tone, and are there any other concerns that she has? And certainly we know that 2 months old is a little early for a child to be rolling over, and we wouldn't refer for just that. But I actually had a mother of a 2-month-old infant ask me about this at the two-month visit, and it turned out that child had a very severe neuromuscular disorder, and there was a problem with muscle tone, and the baby was just, she described, a lot more floppy than her other children, and this was her fourth child, and she just knew something was wrong. So in general, a 2-month-old not rolling over, we would not refer, but always, when a parent raises a concern, do a thorough assessment of what else is going on. And in this particular case, the infant did need to be referred and unfortunately had a life-limiting neuromuscular disorder, and the baby died before the first birthday. So now let's shift our focus to the 4-month evaluation. And once again, as we move into the 4-month visit, we're going to do that interim history, and we'll usually start with the parents' concerns, but then we're going to ask about nutrition. So we need to evaluate if the mom's getting adequate nutrition, if she's continuing to breastfeed, and we're going to ask about the baby's feeding. And is it breast milk or iron fortified formula? Offer water if the child's outside in the summer, and the introduction of solids between 4 to 6 months. We're also going to ask about elimination, just like we did for the 2-month visit. And by the way, I didn't mention this, but usually practices have either a template built into the electronic health record or a paper sort of record that kind of guides you through remembering what the critical things to ask and the critical anticipatory guidance to provide at each one of these visits. So for elimination, once again, we're going to ask about the frequency, and the frequency depends on the milk type and the regularity. So for the breastfed child, it usually remains pretty unformed and less frequent stools, changes with the introduction of solids, and again, you want to have wet diapers with each feeding, and the stools will vary. Breastfed babies can become pretty infrequent. Bottle-fed babies usually have a couple stools a day, and with introduction of solids, the number of stools increases. Sleep, we want to evaluate as well, and they begin to consolidate into longer sleep periods. Finally, should be sleeping 6 to 8 hours at a stretch, and a total of 15 hours a day again. They can be awake for roughly 2-hour periods with less fussing. Their kind of napping period starts with longer awake periods. And crying when put to bed is common at this age because the baby is becoming aware of separation. And this is a good time for parents to know that a child can be given a pacifier and or self-console to sleep, and that they don't have to be held the entire time until they go to sleep. We also want to ask about health problems, but they should be infrequent at this age, and prepare the parents for potential illnesses, asking about taking a temperature, calling the office with any vomiting, diarrhea, fever. We also want to talk about safety. We want to make sure the child's in the proper size car seat and that it's being attached properly, rear facing still. We want to talk about toys and choking hazards, the access to sibling toys if they have older brothers and sisters. Ingestions can become a concern. They put everything in their mouth. Careful consideration of crib toys. We want to make sure that they can't get their little heads stuck or have access to curtains or anything like that where they could strangle. The whole problem with falling off couches and falling off tables and making sure that they are not going to be left on anything where they could fall. So the immunizations for a 4-month-old include the second hepatitis B if it hasn't already been given, but traditionally the child gets the first one in the hospital and the second one at the 2-month visit. So you only want to give it at the 4-month visit if one of those first two was missed. And then the second rotavirus, DTaP, Hib, PCV and IPV are traditionally given, but as I've said a million times, please pay attention to the current recommendations because they change frequently. We're going to evaluate growth and development, and remember our influence of the psychosocial development by Erickson, the basic trust, adaptation through experience, and you want to provide an environment that gives adequate physical care and consistent loving attention, fosters the feeling that the kid is in a safe place and a dependable, predictable place where their needs will be met. The intellectual development Piaget addressed from 4 to 6 months with the automatic and random reactions, progressing to purposeful, repetitive activities so that they learn these patterns of intentional actions. And the child anticipates and waits for feeding and to be picked up. And when they hear the parent's voice, they can sometimes calm, knowing that their needs are going to be met. They gurgle, smile, fusses, or cries as a response to having their needs met. The developmental milestones we expect at 4 months, the rolling from front to back, should be able to hold their head at midline. When prone, hold their face at least 90 degrees off the flat surface. Their hands should be coming together. They should reach, grasp, and mouth an object. Hold the rattle placed in their hand. Evaluation of the language in the 2 to 4 month old infant. We should see some receptive skills, prolonged attention to sound. We should see response to familiar voice. We should see the child really paying attention to the speaking mouth and enjoy the rattle. The child at this age also will shift their gaze back and forth between sounds. And for expressive skills, we want them to begin to make some vowel sounds. We want to hear cooing and blowing bubbles. And we want to have them do the raspberry sounds with their mouth and enjoy using their tongue and lips. Reciprocal cooing should be prevalent in the 2 to 4 month old infant. And that reciprocal play dialogue where the mother or the caregiver makes a sound and then the child responds with a sound, and then the mother or caregiver responds with another sound, and the child responds with moving extremities and makes more sounds. So that's the play dialogue that we expect at this age. Indications for referral are no response to pleasing sounds and doesn't attend to voices. Now the growth and development in the 4 month evaluation, we're going to really look that the child localizes sound bilaterally, laughs, coos, makes sounds of consonants, varies the tone of vocalization, recognizes familiar faces and objects, discovers their hands and feet. Many times the little toe will go to the mouth like you saw in the photo on the previous slide. And the child should begin to entertain themselves for 10 to 15 minutes. We also expect them to double their birth weight by 4 to 6 months. Some developmental red flags at the 4-month visit are again related to the sleep-wake cycle and their behavior. Any child who's difficult to console at 4 months, we need to have some further evaluation. Easily overstimulated, that child needs further evaluation. Sleeps a lot or very little, needs further assessment. Tremors or jitteriness. Additional red flags related to feeding and fine motor. If they're arching their back or cries with feeding, if they're difficult to give the appropriate volume, as we said before, 40 minutes for feeding is too long, they need referral. Gagging or choking with feedings, does not enjoy. Some developmental red flags that we worry about at the 4-month visit are listed for you here. We worry if there is a persistence of primitive reflexes in the 4-month-old. If there's asymmetric reflexes, that's a huge red flag, or asymmetry in their movements. If they persist with fisted hands and have scissoring or hypertonia, those are indicators of CP, as we've mentioned before. And then children who resist being placed on their stomach, that's particularly concerning in the child who's never had tummy time. It may be common, but in a child who's consistently resistant, even though they've been tried on their tummy and regular tummy time tried, that can be a problem. Hypotonia is equally as concerning, difficulty holding their head up while supported, and that can also be signs of CP and just different parts of their brain involved. We also worry if there are delays in social interaction and language development, so no facial interaction or smiling, little interest in their surroundings, or if you're playing with them and you just can't get their attention, if they don't have any self-soothing behaviors like bringing their fingers to their mouth. And also we want to pay attention with the anticipatory guidance to the safety. Discuss with the family the risk of falls, small objects getting put in their mouth. Reinforce that walkers and saucers and jumpers are not only dangerous but actually inhibit the normal gross motor development, and talk about keeping the child protected from the sun exposure, and also that this is a good time to introduce solids. And then, of course, the 4-month visit also has the immunizations. So, the introduction of solids should begin at 4 to 6 months of age, and it's not based on age alone. We really want to look at the readiness for supplemental foods, and that depends on their developmental maturity, their growth rate, and their nutritional needs. The introduction of solids begins with rice cereal. We mix with breast milk or formula and begin with 1 to 2 tablespoons once or twice a day. And they increase really slowly to 1/3 to half a cup twice a day. Then they can begin to add additional new foods every 4 to 6 days. You can add either vegetables or fruit, working up to 3 to 4 tablespoons twice a day. The eventual goal is 3 solid meals per day, approximately by 6 months of age. So breakfast can be cereal plus a fruit, lunch, fruit and a vegetable, and dinner, vegetable and a cereal. But we want to start with just rice cereal, 1 to 2 tablespoons, once or twice a day, and give the child 4 to 7 days before we introduce a new food. Then start with 1 fruit or 1 vegetable, and again 3 to 4 tablespoons, and see how the child tolerates it before you add anything else. Baby food that can be given is either jarred foods, and make sure that it's no salt or no sugar added, or the parents can prepare their own foods, and they may use fresh, frozen, or canned fruits and vegetables. Again, no sugar and no salt added. They can, if they're using fresh, they can overcook the foods so that they're the right consistency, and grind or blenderize those foods so that they can be given to the baby. Toys for the 3 to 6 month old, multi-textured and bright colors, unbreakable mirrors, they love to look at themselves in the mirror, floating bath toys while they're in the tub but never left alone in the water. Things that make sounds are very interesting to them, and solid objects to hold to their mouth. We've talked a little bit about this baby walker dilemma, and I just want you to be aware that the data suggests that with these newer and safer designed walkers, that they have decreased some of the accidents, but the child now can't see their feet and legs, and that visual feedback about their body position and their limb movement is really necessary for the development of their motor milestones, and so it delays their gross motor development. We also know that studies have shown that kids in walkers versus those with no walkers have delays. They sat, crawled, walked later than the control group, and also had lower scores on the Bailey mental and motor development scales. So, advise no walkers. The walker group used the group that used walkers consistently scored lower on the Bailey for as long as 10 months after the initial use. And the walkers continue to be responsible for more injuries than any other type of product, and those include fractures, burns, head injuries, fingers getting caught, amputated, and dental injuries. They're just not a good option, and they've actually been outlawed in some countries. Red flags at the 4-month visit: really evaluate the competency of the parents and in their ability to identify the infant's needs, preferences, interests, and just how the parenting is going. Make sure that there's some attachment, and that any concerns around attachment are referred. And then, do they identify the child's temperament? And if this is a difficult infant, and some kids have a difficult temperament, and the parents are having trouble dealing with that difficult temperament, that they're referred for some support. So let's now do our 4-month case study. Miss Pena is the mother of a 4-month-old, Roberto, and she's noticed a change in his eating pattern. She has difficulty, he has begun requiring extra nursing in addition to the 8 to 10 breastfeedings a day he's already receiving. His birth weight was 7 pounds, and his weight today is 15.3. His elimination patterns are entirely normal, and he's begun to awaken one additional time at night, and mom wonders if he's ready for solids. What additional information do you need to know about Roberto before you provide guidance to this mom? Take a few minutes and think about it, and then we'll move on. So you need some additional information on his physical development, and you note today that Roberto's able to sit with some support. He does bring things to his mouth, and he has doubled his birth weight. So what are you going to advise this mom? Sounds like Roberto's ready to start with solids, and you'll talk about starting with rice cereal, 1 to 2 tablespoons once a day, see how he tolerates it. After 4 to 7 days, if there's no diarrhea, no rashes, no difficulty with that suggests either intolerance from a GI perspective or intolerance from an allergy perspective, then she could begin to introduce either fruits or vegetables, starting with one new food at a time. And have fun with well child visits for 2 and 4 month olds. So we said Roberto meets the criteria because he doubled his birth weight. He's showing the developmental signs of being ready. He meets the minimum age criteria. He's sitting, he's mouthing toys, he has an increased appetite, obviously, because he's waking so much at night. So he should start solids.